Actually, we are live. Let's get started.
Good.
So, good afternoon, good evening to everyone in the US and on the other side of the Atlantic. My name is Mani Mohindru, and I'm the CEO of a young biotech company that was spun out of Recursion Pharma earlier this year. CereXis is working on rare tumors, and our lead program is focused on neurofibromatosis type 2, or NF2, the topic of today's webinar. But before I proceed with the introduction of our esteemed panelists, there are some housekeeping items that I would like to mention up front. We do have live captioning for today's event. If you want to see the captions, please click the closed caption button at the bottom of your screen and select Show Subtitles. The settings can be adjusted to make them as small or as large as you would like. You may also find it helpful to click the View Full Transcript option, which will allow you to see the full captioning. The format of today's session would be question and answers only, moderated by my colleague, Dr. Ajay Agarwal, the Chief Medical Officer of CereXis, and myself. All attendees will be in the on mute-only mode during the moderated part of the session, but can send in their questions via the chat button at any time, and we will try our best to address them during the course of our discussion. Now, we're extremely pleased to have two very distinguished physician scientists today with us who've been involved in the understanding and management of NF2 for a long time and really don't need much of an introduction. We have Dr. Gareth Evans with us today. He's the Professor of Medical Genetics and Cancer Epidemiology at the University of Manchester, UK. He's the author of the famous Manchester criteria, widely used to establish diagnosis of NF2, and has several landmark publications on the disease. Dr. Evans is a member of CereXis's Scientific Advisory Board. We also have with us today Dr. Brad Welling, an endowed professor and chair of otology and laryngology at the Harvard Medical School, and chief of otolaryngology at Mass Ear and Eye. His clinical expertise focuses on hearing loss, facial paralysis, and deafness related to NF2, and his research efforts are focused on NF2-associated vestibular schwannomas. Dr. Welling is also a consultant for the company. Importantly, we are very thankful to NF2 BioSolutions for being our partners for this webinar today and providing a lot of the logistical support. We have with us today Jill Atlin, VP of NF2 BioSolutions. I would now like to invite Jill now to say a few words about the organization. Jill?
Thank you very much, Dr. Welling and Dr. Evans, for your participation in this webinar. And thanks to CereXis, Mani and AJ for hosting this webinar and joining the fight. We're also happy to have Dr. Welling joining our NF2 BioSolutions Scientific Advisory Board. And for your information as well, Dr. Evans is on our board of trustee of NF2 BioSolutions branch in UK. So interacting often with Dr. Evans and Dr. Welling, I can tell you that they are both very committed to the NF2 community. They're extremely collaborative in research and are helping so much in the process of finding a cure. A few words about myself and NF2 BioSolutions. My daughter Karen is 12 years old with NF2. She had already several surgeries, and she's the reason why I volunteer as the vice president of NF2 BioSolutions. That is a non-profit led by NF2 patients and families. So the goal of NF2 BioSolutions is to identify novel therapy platform and approach, check if it could be applied on NF2, and if yes, we jumpstart the research, we fund it, and do our best to accelerate it by removing the roadblocks that the labs are facing. So please check our website and continue to support, volunteer, and donate to our nonprofits so we can have a long-term therapy for NF2 as soon as possible. Thank you very much, and back to you, Mani.
Thank you, Jill. Now maybe let's get right on to our questions. Let's start with you, Dr. Welling, since you're on my extreme right, starting from the beginning. Tell us how you got involved with NF2 and some of your work in the field, both from a research perspective, from understanding the molecular basis of NF2, to the amazing clinical work that you've done over the past several years. Dr. Welling.
Well, thank you very much. This is a great honor to speak to all of you today, and especially it's a great honor to share the platform with Dr. Gareth Evans, whose work I have greatly admired. I learn from him every time we get together, and he is just one of the brightest lights in the field. So I really appreciate the chance to present with Dr. Evans today, and thank you for the opportunity. I have probably seen patients with NF2 for about 35 years, and I'm hesitant to say that because you all know I'm only 40 years old. I've been working on this most of my life, but I will say that when I was in medical school, I was very impressed when we were able to do a surgery and restore a patient's hearing, how miraculous it was. And when I was in medical school, it was just when cochlear implants were coming on the scene, and to be able to restore hearing to patients, it reminded me of what Helen Keller said: blindness takes us out of contact with things, deafness takes us out of contact with people. And so I've always had a great love for the ability that we have to try to preserve that thing that makes us so special as human beings, which is to be able to communicate with each other, to hear and speak, and to be involved in the medical specialty that deals in those has been a great influence on me, and it's been something I've really enjoyed. But NF2 is something I really hate. I mean, it takes away so many of these things, and it makes it so difficult for patients that trying to find solutions has been fits and starts. You know, I think that when we discovered the gene, when I say we as a community, when Jim Casella's group here in Boston and the group with Guy Rouleau up in Canada discovered the gene in 1993, we all thought, this is a gene we can fix. This is something we can get our hands around. And here it is more than 25 years later, and we're still trying to get the fix. So I think that the research that has come out of our labs, I have to credit Longsheng Cheng, who's my collaborator at Ohio State for 25 years, and my collaborators here in Boston at Mass Eye and Ear and Mass General, who have done tremendous work. I've really enjoyed working with them, and I'll just say that I'm stepping down from my chair as the department head as of the beginning of August, so I'll have a little more time to focus on important things like NF research. And I will turn it over to Gareth for his opening statement.
Well, thank you, Brad, and thank you for your kind words. You've been at it a bit longer than me, so my journey started in 1990. Actually, I left the Army. I was an Army doctor, and I went straight from doing pediatrics in the Army into doing genetics in Manchester. And I was given a 2 to 3 year period to do research on tumor or cancer genetics and set up cancer genetic services. And I basically decided we had some good researchers in Manchester, a guy called Tom Strachan, who was doing genetic research at the time, and Richard Ramsden, who was one of the foremost otolaryngologists who actually pioneered cochlear implants in the UK. And I decided that NF2 was just the right place to do my research. So I did a 2-year research thesis on NF2. I went all around the UK. I saw 100 patients in their homes, including Claire's husband when he was quite a bit younger. And I learned about NF, and it was the perfect way. And of course, having seen 100 patients in 2 years, I was able to sort of put it all in the air and say, look, what makes the diagnosis? Because you see lots of families and how it affects people in families. And they sort of stood the test of time, although the criteria are now being changed. There are some flaws in the criteria that require tweaking. Not massive flaws, but there are a few flaws. So, and really, I've dedicated myself to NF2 ever since. And I'll talk later about how we've developed services in the UK. But essentially, I've worked with NF2 patients. I now do a clinic once a week where I see patients with NF2, usually 5 or 6. I want to find the solution, to how we can help NF2 patients not lose their hearing, not lose their function, live a normal life. And I think we're on the road there. and I really hope we get there quickly.
This is great, and certainly, you know, the work that you've done is not just with the patients, you know, it's with the families, because it's a community, and you've looked at the genetics and also, so certainly. And I'm going to go back to you, Dr. Evans, maybe to expand a little bit further, since you worked, you know, over the years on NF2. Maybe talk about the various tumors associated with NF2, vestibular schwannomas, meningiomas, others, and what kind of clinical features do you see in different tumors?
So obviously the hallmark of NF2 is the development of bilateral tumors on the hearing and balance nerves that we call vestibular schwannomas. And these particular nerve sheath tumors that grow on the nerve sheath, called schwannomas, are the characteristic lesion. And the schwannomas can occur anywhere else in the body where there are Schwann cells. So on most of the other cranial nerves, all of the spinal nerve roots, and then on the major nerves around the body. And you can get these nodular swellings on the nerves under the skin in the arms and legs, but you can also get them actually in the skin itself. So that sometimes gives confusion with NF1, because you get tumors in the skin, but they're different. Most of them are what we call Clarkey lesions with hair on them. So the schwannomas occur all around the body. Meningiomas are the second most important tumors, and about 70% will get a meningioma in their lifetime. And these are tumors on the lining of the brain, and less commonly on the lining of the meninges around the spinal cord. And those are really important in terms of morbidity now that we're better at treating the schwannomas. And then the final major tumor that occurs in about 20–25% of people with NF2 are an intrinsic tumor in the spinal cord, usually in the cervical spine, but they can dot down further down in the spine and occasionally into the brainstem itself. They're usually indolent, and they can look terrible on a scan, but you have to judge when is the right time to do something about them, and usually you don't. But they can be a tricky one when you look at a scan and the patient has no symptoms. What do we do about this? And then suddenly patients have symptoms. So those are the three main tumor types that you get in NF2. And then there are some additional features, like in the eyes, particularly cataracts, that don't usually cause any visual problems. They're just what we call presenile or juvenile cataracts. And occasionally also a congenital lesion on the retina, usually again doesn't cause any problems, called a retinal hamartoma. And then there are some other subtle features that we see, but those are the main features.
Next question is for you, both Dr. Evans and Dr. Welling. So can you help us understand the challenges associated with this disease, both from the perspective of the patients as well as the patients' families? What kind of symptoms and what kind of other challenges they face in their day-to-day lives? So we'll start with you, Dr. Evans.
So, well, the main thing that affects pretty much everyone with NF2, even the mildest family, they nearly always get tumors on both sides, both hearing and balance nerves. And it's very rare that those do not require treatment at some stage. So nearly always you will get hearing loss, unless you have a brilliant surgeon who takes the tumor out, preserves hearing, but then they can come back, and you've got to deal with it again, and that's a tricky thing to do. You've got radiation as another thing. We're not that keen on using radiation in NF2 because a small malignant potential, and also it doesn't work anything like as well in NF2 as it does in the sporadic situation. So surgery is still by far the most important thing. But the problem in NF2 is you can just get a proliferation of tumors. And people can end up having 2 or 3 spinal surgeries, 3 or 4 meningioma surgeries. And there comes a time when someone throws in the towel, either the surgeon or the patient says, I don't want any more. And that is why it's critical to come up with a treatment that means that we put Brad out to grass before he needs to go out to grass, so that we'll still need you, Brad. But you know, it really, I think nearly every surgeon will say they would rather we could cure NF2 than have to operate so many times on NF2. And the problem is the loss of hearing. There can often be problems with vision. So although the cataracts don't cause blindness, treating the tumors can cause problems with vision, because you get the facial nerve palsies, means that the windscreen wipers don't work very well on your eyes, and you get corneal keratopathy that clouds the vision. Often one eye doesn't see very well. You get a condition called amblyopia, which means you're often more dependent on one side. And then you've got the meningioma problem, and multiple meningiomas can often mean raised intracranial pressure, and trying to deal with that side of things, and then obviously the trickiness of operating on the spine.
Yeah,
and in the families, it's obviously coming up with a test so that you can preempt and diagnose the condition earlier in the children. It's a 50-50 risk normally, but actually nearly 50% of new onset NF2s are what we call mosaics. So the genetic fault was not inherited from their parents. It actually developed as they developed as an embryo, and only affects some of their cells, not all of their cells, enough to cause them multiple tumors. And in those individuals, it depends on how many cells are around in other cell types, like in their gonads, in their ovaries or sperm cells, that will determine the risk to their children. But if they do pass it on, they have mild NF2 because it's only in some of the cells. They will pass on a severe form of NF2 to their children because it'll be in all the cells.
Gareth, somebody just asked how you can tell if you're a mosaic or not. Do you want to, maybe you just answered that, but.
Okay, so the main way is that we initially do test on blood, and you have 2 copies of the gene. So when you see a spelling mistake, it should be at 50% allele frequency, because only 50% of the normal cells carry the genetic fault. So often we see mosaicism when we see it in only 10% of cells, or sometimes 5%, or even lower now. We can detect it down to about 2% now with next generation sequencing. But often we don't see it at all in the blood, and we actually have to test 2 tumors to find an identical mutation in 2 tumors, and then we can go back to the blood and check it in the blood, and we can check it in sperm cells actually to check whether there's any likelihood of passing it on, if you already know what the genetic fault is by testing 2 tumors.
Well, I'm going to jump back and say a word about how this affects patients and their families from my perspective. I think that I mean, I completely agree with what Dr. Evans just said. I think there's a challenge because people call this a benign disease, but really it doesn't act benign. You know, it can cause such devastating problems, and yet other people may not understand the difference between an aggressive disease like this that can take away function and take away life, and a cancer that's going to spread to other places quickly and cause death. And I think it leaves families in the lurch a little bit. I think that it's difficult to get the attention of the National Cancer Institute when we talk to them about a disease that is not typically malignant. We can't get the funding that they get for colon cancer or breast cancer. I feel like there are challenges in communication, not only because of deafness and the blindness, as Dr. Evans stated. Patients who have a facial paralysis that don't cover their cornea can also have an anesthetic effect from one of the tumors, so that they don't feel that their eye is irritated, and then they're much more likely to cause this corneal opacification that can cause blindness. And it's a very, I think one of the frustrating things I see for families is that we don't have a straight course forward. We don't say to you, here's what you do, A, B, C, D, and this is the end of it. It's a very unknown course, and there are a lot of decision trees all along the way where each case is different and you have to weigh so many different things. Now, I think the tool set we have is much better now than it was 10 years ago or 20 years ago. One of the things that I credit Dr. Evanson's group with is the genotype phenotype correlation, the specificity of knowing where the mutation is and being able to predict how severe the patient's going to be with their disease, knowing where the mutation is and what type of mutation it is. And that database took a long time to accumulate over many years, decades, a couple of decades really, but that's an important tool. We're getting better at our imaging. We're getting better at detection of mutations. And I think that in some situations when we know that a young patient inherits the disease from a parent, to intervene early on can save a lot of problems, but we still don't cure this disease with a knife. It's a genetic disease and we need to find other better solutions. So I think another challenge is that we've struggled to get good mouse models or good animal models for this disease. Mice and humans are not the same. And as much as we like to think that we can target mice and have it translate into men, that doesn't always work. And it's not just in this disease process, but in a number of processes. So getting good models is difficult. I think another big challenge that we all face in the field who are trying to get to better treatments is it's not only got to be safe and effective, it's got to be just really well tolerated for a long period of time until we get to a cure. And so if you've got a disease that's going to take your life within a year, you can tolerate being miserable and sick on the chemotherapy, but that's not something we want to do for our NF2 patients. It limits a little bit the pathways we can go down. So I think the fear of the unknown and just not really having great answers, there are always nuances about how we're going to treat patients, makes it difficult for patients and for families and for us too. I mean, we always want to choose the best treatment and sometimes we don't know exactly what that is.
Yeah, so maybe, expanding on some of the things that you've talked about, you certainly are, our surgeon, so that's sort of how you manage a lot of these patients, even though it's not ideal. So I just wanted to drill down a little bit further from your perspective as a healthcare and as you work with patients and the families in the setting of surgery in the setting of NF2, or rather multiple surgeries in the setting of NF2. So how do you deal with it and all the risks associated with it in consultation with the families? It's something, as you both have said, Dr. Evans has said as well, like it's not just one surgery and that's the end of it. So how do you sort of get to that decision making and the course of action?
Mm-hmm. Well, I think that we try to prioritize the various aspects of the disease. And the one at the top of the list is always, is this a life-threatening tumor? Is this something that's going to cause the patient to die if we don't take care of it? If that's the case, that's usually an easier decision to say, we need to take this tumor out. If it's compressing the brainstem to the point it's going to block the flow of spinal fluid and cause a massive pressure in the head, then that's an easier decision. Not that it's a pleasant decision, but it's not that there's a lot of option with that type of a tumor. But the difficulty comes with smaller tumors that particularly, for example, let's say a tumor that's on the balance nerve that's compressing the hearing nerve, but the hearing's still functional, and there's one on the other side, and that's also not knocked out the function yet. The hearing is still reasonably good, but as the tumors grow, they're going to compress the brainstem if something's not done. And when do you decide to operate as opposed to preserve function? Well, those are difficult decisions. And another unknown that comes in is, when are we going to have a drug that will stop or shrink these tumors? And so it may be that 10 years ago or 5 years ago, I would have said, this tumor's got to come out. We're not that close to finding something that may work. But we hope, we think that as we get closer, we get more likely to have treatments. It still is a very difficult decision to make. And one of the things that I would say is maybe unique to my perspective, and I would say that there are others who would agree with me, but there are many who may not when it comes to surgery, is that when tumors are small enough that we might save the hearing, usually in my book, that means less than a centimeter in diameter and not really impacted into the inner ear. They have a little bit of space there where we can work safely. Then taking out the tumor, although it does present a risk to the hearing, does also present the opportunity to potentially save the cochlear nerve, the one that carries the hearing fibers. And intervening early in that case may save the hearing, or if you don't, you may save the cochlear fibers. And in a small series that we did that's really not scientifically very sound, because we only had 7 patients and there were a retrospective group of patients, I just say that we were much more successful in those patients at giving them a cochlear implant and having them be able to hear reasonably well than we've been in our patients who have no cochlear nerve preserved and we have to do an auditory brainstem implant. The auditory brainstem implant most often gives people sound awareness, but only in about 12% do they get any open set speech recognition so that they can understand words without lip reading. And people find that it's helpful and they find that sound awareness is very beneficial, but being able to understand words without lip reading is much better. And so sometimes we make a decision to intervene early with the knowledge that even if we lose the hearing in the surgery, that we could use a cochlear implant later on and preserve that important communication ability. So I think that I've had patients who've said to me, no mas, I don't want any more surgery. And we said, if you don't operate on this tumor, it's going to cause serious problems. And they said, I don't care, I've had enough, I'm not willing to do it. And that's a sad state to get to, but I can understand that people can get tired of having surgeries. Most of the time, they don't come out of the surgeries better than they went in. Most of the time, it's really to try to preserve their function where they are. And it's rare that they actually get better from surgery. So I can understand their point of view, but I hate to see people throw in the towel too. And I think that we'd love to have better treatment options.
Yeah, no, that's a good perspective. And Dr. Evans, just, you know, you're obviously based in UK, sorry. You probably have
I did once go to a CTF meeting and they bought me a ticket from Manchester to Aspen. The only problem was it was Manchester, New Hampshire. And the ticket wasn't any use to me when I got to the airport.
So maybe coming back here, so how is the practice different or similar in your side of the world versus here in terms of management, maybe specifically the investigation?
I mean, I think it will be very similar in the sense that Brad is part of a team and a multidisciplinary team, and they make decisions as a team rather than an individual surgeon. With the patient, and, you know, obviously advising the patient what the best course of action is, but there is an element of choice. But what we built up very early on in Manchester was a multidisciplinary team clinic where we had a neurosurgeon, an ENT surgeon, a neuroradiologist, so a radiologist that spent hours looking at the scans before the meeting, myself as a sort of physician who would look at the patient in the morning and check any new problems, do a neurological examination. We now have neurologists in addition to me to do that. And that eventually led to, we applied for something called highly specialized services, which meant we actually located only 4 clinics that looked after all NF2 patients in England. So 55 million people are looked after by only 4 centers. Now, some of those centers do outreach clinics so that they can be seen nearer to their home by a local team with a member of the core center there. But essentially, virtually all those patients are managed by 4 centers. So that's at the moment about 920 patients in England. We know all the patients, we've got all their data, and it enables us to have totally coordinated care where they're seen at least once a year by the full team. And they have, you know, we have audiologists, ophthalmologists, physios, nurses, all of those people involved in the clinic and involved with helping them. So it's a one-stop shop for them. They don't have to go to, you know, pillar to post to see different specialists. And, you know, we're extremely lucky in the UK with socialized healthcare that is one of the great things that it's able to supply, is this highly specialized care. And we're sure that this has had a major effect on survival. It meant we had access in 2010 with very specific circumstances to the use of bevacizumab, Avastin treatment, because of the fantastic work that had been done in Boston by Scott Plotkin to find that it was effective in treating growing schwannomas. It doesn't work for meningiomas, which is a problem, and that's why we need another drug. It also long-term causes problems with the kidney and with blood pressure, and that's why we need another drug. Because if you take people off of Avastin, the tumors usually come back. It only keeps them at bay. It doesn't kill them. It just stops them, shrinks them a bit, and then they start coming back again. So we need a more permanent solution, or at least a solution that has less long-term side effects in terms of the effects on the kidneys.
That is helpful, maybe AJ. Yeah.
So next question, building up on your answer, Dr. Evans, do you think achieving tumor stasis or stable disease is a meaningful treatment goal for your patients, and you as a treating physician, would you think it as a meaningful goal? And just from your perspective, Dr. Evans.
Yeah, so I mean, stable disease in NF2, if you can find someone who's asymptomatic and just stop everything, then that's as good as a cure, because it's a benign disease. The tumors aren't going to spread. If you just stop them all, then that's fantastic, because they can live a normal life with just a few internal tumors that are stopped at that stage, frozen at that stage. Now, I guess reality won't necessarily be as easy as that, but you do not need to shrink the tumors to make a difference. If you get in there early enough, you can just stop it before people lose hearing, before people lose balance, before people lose other functions in terms of, you know, their ability to ambulate and to live a normal life. So absolutely, maintaining stable disease or making it stable is extremely good. You can't do that with cancer, because a cancer might be stable, but then it can metastasize. And so it's a very different scenario to treating a cancer where you need to do more than just keep the tumor stable.
Yeah, I completely agree. And one of the tricky things about it, as we discussed before, is that most of the funding agencies in the United States, and I don't know how it is in the UK, but most of the funding agencies in the United States do not look at that as a reasonable endpoint. They want to see the tumor shrink and go away, because they're used to funding cancer treatments, not benign, quote unquote, benign disease. I like the terminology tumor predisposing syndrome more than I like benign disease, because it does predispose to a lot of tumors. But yes, I think that stabilization is an ideal endpoint. If we could just know how to turn off the tumors from growing, that would be sufficient. We're getting a lot of good questions coming in.
Yes.
I know that we have other questions to answer. Do you want to go to some from the audience?
Yes.
Or how do you want to do
so
that?
Maybe, you know, since we have you talking, Dr. Welling, maybe you can talk about why are the vestibular schwannomas in NF2 usually the first ones to develop as opposed to other schwannomas? Is that the case, and maybe why?
I can tell you exactly. I don't know. I wish I did. You know, that's my life goal, actually, to figure out why vestibular schwannomas are more likely to occur than any of the other cranial nerve schwannomas. They're 9 or 10 times more likely than any of the others. And I honestly don't know. I've hypothesized a lot of different things. It seems like certain viruses like to get into certain types of nerves, and the balanced nerves are some that seem to attract some particular viruses. Is there a viral etiology that turns off one of the tumor suppressor genes? Maybe. I don't know. We know that patients who've had radiation are more likely to get that gene turned off. The survivors of the blast in Hiroshima and Nagasaki had far more of these type of tumors than others. Radiation can do it, but neither of those are really very satisfying, and particularly in somebody who inherits the disease, who inherits mutations as in NF2, why is it the vestibular nerves get them before the others? I don't know. I mean, Dr. Evans can probably tell us. I've been waiting to hear.
Well, no, all I will say is that it's not peculiar to NF2, because NF2 just mirrors what happens in sporadic tumors, because half of all schwannomas occur on the vestibular nerves.
Yep.
And that means that clearly they are going to be the primary site, because the other sites are much less common individually. So, and what we see, which is quite astonishing when with the fantastic MRIs that we have now, when we scan people who've inherited NF2 before they get symptoms, is we see dotted along both vestibular nerves, sometimes 3, 4, 5 separate starting points for tumors. And you don't really see that anywhere else. It's just the vestibular nerves where that occurs. And it used to be thought that there was something special about the glial Schwann cell junction, that was really important on the vestibular nerve. And that's nonsense, because they occur all the way along the nerve. And we don't know. We don't know why that nerve. I think Brad's got some good points. Maybe it's a nerve that, you know, we're using all the time, like we're using our balance all the time, but that still doesn't really explain it. But there is something about the vestibular nerve, not just in NF2, but in people in general, that is much more susceptible to developing tumors. And NF2 is just a reflection of that, except that you get many, many more schwannomas. And in NF2, instead of getting one schwannoma on the vestibular nerve, you get a bunch of grapes that wrap around all the other nerves. And that's why it's very hard to treat the vestibular schwannomas in NF2, and why, you know, facial nerve weakness afterwards is more common. And why also radiotherapy doesn't work as well, because you'll treat what you think is the middle of the tumor to try and treat the rest of it, and the few grapes on the outside won't get a lethal dose of radiotherapy and will regrow. So, you know, that is why the treatments are much harder. There's something really odd about the nerve we still don't understand, but the Nobel Prize will probably have to go to someone in the next generation, Brad.
I don't know. I've got some smart people here. It won't be me, but maybe some of our folks will figure it out.
So I do know we're running short of time here, but I do want to cover 2 topics since I have the 2 of you here. One, you know, maybe Dr. Evans, since you've been talking, like, you know, expand on your work on the epidemiology of the disease. You know, you've obviously spent a lot of years studying this rare disease and going to patients' houses and everything, as you mentioned already. So give us your first-hand perspective on what's the numbers, what's the epidemiology, the prevalence of this disease. Yeah. And so, everybody comes back to you. You know, your paper is into you.
Yeah, well, there's only been one other epidemiological study in the world, and that was in Finland, where they did a very small study. And we've now got effectively a whole epidemiological study in the UK, because we cover the whole of the UK. And we've now remapped what I did before, and essentially it's the same all around the UK, which means it'll be the same all around the world. The mutation rate is so high, the new mutation rate, more than, I mean, the literature says 50% of NF2 are familial, 50% on de novo. It's much more than that are de novo. It's about 70%. If you count the mosaics. And so what you have is about 1 in 27,000 people are born with NF2, that they have that susceptibility. They're not born with the tumors, they're born with an NF2 mutation in all of their cells or quite a lot of their cells at birth. So they are programmed, unfortunately, at some point to develop tumors. Now, the next thing that people talk about is prevalence. So that is the number of people diagnosed with the condition at any one point in time. And that is lower than 1 in 27,000 because often the mosaics don't present until they're 40 or 50. So they spend more than half of their life not diagnosed. Therefore, that comes off your incidence. And unfortunately, the severe NF2s don't live a normal life expectancy. So that comes off as well. Mm. So in the end, your prevalence is about twice your half as common as your incidence, about 1 in 50 to 1 in 55,000. And that's in our very, very highly ascertained UK population.
Okay, no, that's good. You know, thing about, yeah, that's always a question that comes up everywhere. You know, what is it? It's not talked about disease. And I know Dr. Welling has obviously discussed this, you know, it's not considered a malignant disease and there's not enough funding. So I'm going to go to you again now, Dr. Welling, to expand a little bit further. Maybe tell us what the landscape looks like from what you are reading and seeing and what's being published. Tell us, you know, some of the promising drug targets or drug candidates or even the pathways that are being used. And I do want to say that there was a question on the chat where they talked about even high FGFR or TNF alpha expression, you know, being associated with higher risk of the disease. So all these things, you know, give us some sense of what's going on from a research perspective in drug development.
Sure. Let me answer Tani's question first in terms of the expression of different factors from the tumors. This is true probably both in NF2 related schwannomas and in sporadic schwannomas, where certain tumors, even though they're small, will knock out the hearing, and we think that may have to do with excretion of certain factors from the tumors like the TNF alpha, and others seem to be more protective, like with fibroblast growth factor type 2. And yes, that research came out of Dr. Stankovic's lab here, and that is ongoing, where we have actually just put in a proposal to look at that in relation to other findings with NF2, the genetics and the vestibular findings and hearing and so forth. So that work is very interesting. And when it comes to the different pathways, one of the things that it seems to me has happened since the gene was discovered, everybody's been working on trying to figure out what is it that Merlin does. When Merlin gets mutated, what pathways go into action to let these cells run up against each other, and instead of stopping with contact inhibition, why do they continue to mound up and these Schwann cells continue to proliferate? And there are so many pathways that we don't have time to talk about all of them today, and I'm not an expert in all of them, but I would say that many of them have drugs that are we can target to them. And one of the efforts that we just were involved in with a consortium called the Synodos Group that was sponsored by the Children's Tumor Foundation was to try to find a large panel of drugs that had already been FDA approved or had gone down the procedure through phase 2 testing at least, so that we thought that they were accessible to us. And we screened a large number of drugs. We initially started with almost 2,000 drugs, and we narrowed that down to 45 that we thought targeted specific pathways. And then we looked at that in cell cultures and in mouse models, and have tried to funnel that down to drugs that we can bring forward to clinical treatment. And so it's been tricky. And I would say that unfortunately, the drugs that seem to target schwannomas don't always target meningiomas. And it would be ideal, of course, to have one drug that would hit both, because those are the two primary tumors, as Dr. Evans explained, that are important. I would say that we also have struggled a little bit with mouse models not reacting. The mouse cell lines don't react exactly as human cell lines would, and human cell lines that have NF2 mutations don't grow very well, so they're hard to use for test. And yet I would say that there are still a number of drugs in the pipeline that are to be tested, and the first one that's coming out of that particular pipeline for a clinical trial is brigatinib, which is a drug that's been used for non-small cell lung cancers. And so it's been approved by the FDA for that use, so we know its profile, we know what it looks like, and we know that it seems to target both meningioma cells and schwannoma cells. And that clinical trial is about to get started. We also have, as you were very well aware at CereXis know, we've worked for many years on a drug that's been called AR42, or now REC-2282, a drug that targets one of the other pathways that regulates cell growth. And we have some preliminary data, both from a phase 1 study where we look at the safety of the drug, and a phase 0 study where we look at the drug getting into the tumors. And this is another study that we hope will get kicked off soon for a phase 2 trial, so we can really look and see how efficacious is this against these tumors. It's possible that we may need combination therapy, that it might be it's not one drug, it may be 2 drugs that we have to use to try to tamp down these multiple different pathways that can occur to release the cells from contact inhibition when they should stop growing. And I think that one of the drugs, the only drug really that we have seen a lot of benefit from, is one that Dr. Evans has already referred to, which is bevacizumab, or Avastin. One of the questions that was asked was, has that been applied directly to the tumor? I don't know if it has, but I do know that there is a group that's proposed that, and I know that that's a mechanism that is going to be looked at if it hasn't already. But I've been amazed. It's taught us interesting things about the pathology of the tumors, that some of the patients do get improvement in their hearing. I never would have believed that. I thought Scott Plotkin was lying to us when he told us that the first time, but it's true. I mean, about 35 or 40% of the patients get an actual improvement in their hearing, mostly in the clarity of their hearing, not as much in the pure tone averages, but so it doesn't get a lot louder, but the clarity improves a lot in some of these patients. And it's encouraging. It's a little clue about what's going on with the hearing loss. It may be that the bevacizumab, or Avastin, is blocking one of the excretion of one of these exosomes that's toxic to the inner ear, and just removing that toxic effect will allow the mechanisms to start working again. So I'm always the optimist, and I always tell people, oh, in 5 years we'll have something, and every 5 years I say that. So I think that at some point we're going to have something that's going to work better than what we have now, and I hope it's sooner rather than later. Lapatinib is another drug that we were involved in a study with, and I'd say that, even though it didn't hit the shrinkage target that was the goal, Matthias Karianis, who carried out this study, showed that a large number of the patients didn't have their tumors advance while they were on lapatinib. It's not without its side effects, but it's encouraging to see other drug studies that are coming forward that seem to have some benefit. And so I think there are a number in the pipeline, but getting them executed and carrying them out is challenging. And I'm hopeful that with the combined efforts of the whole NF2 research community and the support of the NF2 patients, really, I mean, you all do a great job at driving these things forward and supporting the efforts. I'm optimistic that we will get something that will be useful and helpful to stop these things.
Oh, absolutely. We hope so too. We'd love to keep continuing talking to you, and I'm sure the audience too, with wonderful questions coming, but I know we promised you a certain time and you are busy people.
I typed 3 answers.
I grant you that. So thank you so much, Dr. Evans, and Dr. Welling. You have been picking up the questions and addressing some of those as well. So thank you. I hope people in this online webinar, they appreciate that. So I think we should wrap it up. We are 5 minutes over our time, which is good considering the wonderful discussion we've had. So I would like to thank both of you, Dr. Welling and Dr. Evans, again, for taking time out of your busy schedules and providing this wonderful discussion. I hope others benefited from it as much as we did. I also want to thank NF2 BioSolutions, as well as all the patients, family members, and others who are here online with us. This is our first attempt at this webinar, so we appreciate, if you had any glitches or if we couldn't get to most questions. But as we all continue to work towards improving lives affected by NF2, please continue to send us some suggestions, questions. You have my email address in your registration confirmation. Thank you, everyone here who've joined here today, and have a great day. Thank you again.
Thank you all.
And I'm going to
Thank you. Thanks, everyone, and good luck. We need a solution.
Good night. Thanks, Sarah.